Good evening students. In this video we are going to discuss about para-aminohipporic acid excretion, right? Actually the mechanism by which para-aminohipporic acid gets excreted is clinically very important mechanism because many drugs share the same mechanism for its excretion, and also via trying to understand how it is excreted we'll also try to understand a very interesting mechanism of tertiary active transport, right? So let's discuss the mechanism of para-aminohipporic acid excretion, right? For that we have to first draw a cell of PCT, right? So let's first draw a cell of PCT, right? Now, as all of us know that this has got two sides. One side is your basolateral side and other side is your luminal side, right? Now, every time we are going to start with our main hero. Who is our main hero? Our sodium potassium ATPase pump, right? Sodium potassium ATPase pump. Now, since it is pumping the sodium outside and potassium inside, there will be deficiency of sodium inside, right? Every story starts with the same line, right? Now, what's different this time? The PAH excretion, right? You will have one amino acid, glutamate. Right? Now, excretion of glutamate, the metabolism. Now, metabolism of glutamate will give you alpha ketoglutarate. Alpha Kg. In short form, I am writing alpha Kg. Right? Now, this alpha ketoglutarate has to be excreted out. Right? So, over here, you will have organic anion transporters, OAT. Right? Either OAT1 or OAT3, organic anion transporters. Right? These organic anion transporter, right, will exchange. I mean, this alpha ketoglutarate will go outside, and in exchange, the para-aminohipporic acid will come inside. So it's kind of para-aminohipporic and alpha ketoglutarate gets exchanged with the help of these two transporters, either organic anion transporter 1 or organic anion transporter 3, right? Now, this alpha ketoglutarate will go outside. It will go outside, right? Now, what we discussed in the beginning, that since this sodium potassium pump is pumping the sodium outside and pumping potassium inside, there is deficiency of sodium inside. So there is gradient. I mean, we have got higher sodium over here compared to inside, right? So now this alpha ketoglutarate will utilize this gradient to enter inside along with sodium with the help of sodium alpha ketoglutarate synporter. Right? Now, if you pay close attention to this, right? This is our primary mover. This is creating, pumping the sodium ion outside and potassium inside. So we've got less sodium inside, more sodium outside. This creates a gradient, right? Now alpha ketoglutarate is using this gradient to enter inside the cell along with sodium. So this is example of secondary active transport. This is your primary active transport and this is your secondary active transport. Now we have got more alpha ketoglutarate inside, right? Now the alpha ketoglutarate is moving out and now pH is using this gradient to move inside, right? So this is your primary active transport, this is your secondary active transport, and this is your tertiary active transport. Tertiary active transport means a transport which is using the gradient which was created by secondary active transport. Secondary active transport uses a gradient which was created by primary active transport. So this is your primary, this is your secondary, and this is your tertiary active transport, right? So this explains the concept of primary, secondary and tertiary active transport. Now what about the clinical significance portion of this? Now you are seeing this O81 and O83, right? Let's first finish the whole thing. Now when the pH comes over here, if it wants to move out into the lumen and get excreted, it needs a protein called MRP2. Multi-drug resistant protein. It can be either multi-drug resistant protein 2 or O84, right? Either MRP2 or O84 it needs to get excreted out, right? So there are two steps for pH to get excreted out. It will get exchanged in exchange of alpha ketoglutarate with the help of O81, organic anion transporter 1 and organic anion transporter 3, and when it wants to move out into the lumen, right, it needs either MRP2, multi-drug resistant protein 2, or organic anion transporter 4. Now the clinical significance is that this O81 and O83, the multiple drugs actually compete with each other for the same transporter, right? Now what are the drugs which actually compete for the same transporter, right? These drugs are your probenecid, then penicillin, right? Then even furosemide, then even sulfonamides, right? So multiple drugs compete for the same transporter. Probenecid, penicillin, furosemide, sulfonamides, they compete for this one transporter, right? And now why actually this is clinically important? Because in Second World War, the penicillin was yet not in industrial production. Means penicillin was produced, but the methods of penicillin production were inefficient, right? Since the methods were inefficient, penicillin was a costly drug and doctors wanted the penicillin to stay in body for long periods, right? So what they did, they will give probenecid. Now probenecid is a drug we give in gout, right? But in Second World War, they gave probenecid along with penicillin. If they give probenecid along with penicillin, then what is going to happen is that the probenecid is going to occupy these transporters, right? Probenecid is going to occupy these transporters, right? And penicillin won't be able to enter into the PCT cells and won't be able to get excreted out, right? So penicillin will find it tough to enter into the PCT because this O81 and O83 are already saturated. So penicillin will stay in blood for longer period and it's going to cure any infection which might have happened to the patient, right? So this is the clinical significance of the chain through which the pH is excreted out, right? Because many drugs use the same transporters, OAT1 and OAT3, right? So it's a very interesting and a clinically useful mechanism, right? As we said, we first of all draw a PCT, right? Then we draw our hero, our sodium potassium pump, right? And this sodium potassium pump created a gradient, less sodium inside, more sodium outside, right? Then we had this amino acid metabolism, glutamate, which created our alpha ketoglutarate, right? This alpha ketoglutarate will go outside, and in exchange the pH will come inside, through which ion transporters? OAT1 and OAT3. This alpha ketoglutarate will then come inside using the gradient which was created by sodium potassium pump, right? Since this was the primary site which actually created the gradient, this is your primary active transport, right? Using this gradient, the alpha ketoglutarate came in, so this is secondary active transport, and more alpha ketoglutarate, when it moves out, the pH comes in. So this is example of tertiary active transport, right? Now many drugs, probenecid, penicillin, furosemide, sulfonamide, many drugs use this same transporters, OAT1 and OAT3, to enter inside the cell, right? So if you give one of these drugs along with the other drug, they will compete with each other and reduce each other's excretion. This mechanism was used in our Second World War to increase the half-life of penicillin, right? They will give probenecid along with penicillin. Both of them will compete for OAT1 and OAT3, right? And it will increase the half-life of penicillin. Penicillin will stay in body for longer duration, and it helped in curing infection and saving costs during the Second World War, right? So hopefully this video helped you in understanding the mechanism of para-aminohippuric acid excretion, in understanding the phenomena of tertiary active transport, and also in understanding the clinical significance, how in Second World War we prolong the half-life of penicillin by understanding this method, right? Hopefully this video helped you. Wish you all the very best. Thank you.